I don't think my physical exam is all that spectacular per se. It's more so, I guess, just the way my brain naturally starts to think about what is happening with the physical exam. So a few clinical pearls on that is, one, really, obviously it goes without saying, but know how to do the physical exam properly. Because even when I went through school, I was taught probably about 3 or 4 physical exams that were incorrect. And so I ended up getting corrected later by another doc. And then you look back and you go, oh, okay, that makes complete sense. So one, just make sure you're looking at other sources and things like that. Physiopedia is really, really great for looking at, how to do PEs, what they mean, some of the research behind it, stuff like that. So that's one thing, is knowing how to do them. The second thing is knowing what a true positive is. So best case example is straight leg raise, right? The positive is radiating pain down the ipsilateral leg between 30 and 60 degrees of hip flexion. It's not low back pain. So some students that I've trained will report back to me on shift and they'll say that straight leg was positive. And if I don't prod, which I always prod because this happens so often, they had low back pain, which that is really, really important to know that they had low back pain during straight leg raise. But you just have to know that it's not the positive, because if you know that straight leg raise is going to be positive in a disc bulge or disc herniation that is encroaching on the nerve root and causing radicular pain, then you might think their low back pain is now due to a disc bulge or disc herniation, and that's probably not the case. And so understanding what the true positive is and what it means. And then I think the one step further that is helpful is, and again, I think this is where anatomy trains really comes in handy, is understanding the biomechanics of what is happening during this movement pattern, regardless of what some old dead orthopedic surgeon called this thing and said it what it was for. So as an example, with straight leg raise, once you get up past about 60, 70 degrees, you start getting rotation in the ilium and in opposition to the sacrum. And then you also, as you continue up further, you will start to get rotation in your lumbar spine. And so if somebody is getting low back pain and they're at like 80, 90 degrees, I'm thinking, oh, hey, maybe this is indicating that they've got an SI joint problem, or they've got a lumbar facet, or any of the supporting structures around that area. Because then taking that, then that helps me to frame up all the other things I'm doing, as opposed to just saying, oh, straight leg raise was negative, move on. And then the last thing is how I kind of think in terms of what all this stuff means, right? So as I'm going through and when I'm done a physical exam, it's kind of like there's all these different buckets of differential diagnoses. So let's say we got low back pain and after talking with them, I'm suspecting that they might have let's say a disc bulge that's causing some radicular pain. They might have sacroiliitis, because the sacroiliac ligaments can refer pain all the way down to the foot. And it could also be a lumbar facet syndrome, because again, also the facet joints can refer pain down to the foot. So these are kind of my 3 buckets. Then what I'm doing is all of these different exams that are coming in at me are filling up buckets to different degrees. So as an example, if I do Faber and that causes some low back pain, but it does not recreate my patient's low back pain, but then I do a seated Kemp's test and I do that and they're like, that's my pain. Well, now facet syndrome just got a whole bunch of water dumped in that bucket because it recreated their pain. It wasn't just painful. And so even if I end up having a whole bunch of other things and, my SI cluster, I have 4 out of 5, but none of them really recreated their pain except for seated Kemp's, then I would still be strongly considering that it's more of a facet mediated issue, because when I stressed the facet joints, it recreated her pain. And so that's super important. And so I kind of go through all of these things, and mentally in my head, they just kind of fill up these buckets, and then I end up going with the most likely bucket. And sometimes it's not one thing. And actually a lot of times it's not one thing. A lot of times there's multiple layers to patient's pain, especially when it's chronic. If it's acute and someone just tweaked their low back, it's usually just the cluneal nerves. Like straight up, most people who hurt their back in the gym did not blow out a disc. It's usually a mild cluneal neuralgia. And so I'll usually just treat that as long as ortho exams and everything matches up with that. But if you've got someone who's coming in and they've got 30 years of low back pain and they've been moving different, they have not been exercising, it's generally not just, it's just your sacroiliac joint and that's it. There's usually going to be some compensation in other areas. And so there ends up being kind of multiple things that we'll end up treating. And then we kind of assess from there.